Welcome to Phoenix Rising with Dr. Z. This podcast is all about conversations about healing and rising from the ashes of your grief and trauma. In this podcast, we will be deconstructing and highlighting the different aspects of grief and loss. I'm your host, Dr. Christina Zampatella. Okay, we are going to talk about prolonged grief disorder. What the hell is prolonged grief disorder? We're going to find out about what prolonged grief disorder is. I'm going to give you a little bit of history. I'm not going to belabor it, but I think it is important for you to understand that in the research in the field of thanatology, which is death, loss, dying, and grief, all right, in our field, there has been, and there always will be, without a doubt, significant debate on whether or not there is a disorder that can result as in reaction to a loss that seems to be stuck, that grieving process. The definition of stuck, I'm going to tell you a little bit about the definition, but I want to tell you a little bit more about where we're coming from. So, starting in about the 1980s, 1990s, it became a lot more popular for researchers to evaluate and explore this experience that they're noticing with some people who seemed to not be able to move forward in their grieving process. Now, a lot of argument about, well, how much time should it take? If I knew how much time is a normal grieving process, I would not be having this podcast right now. I would be in the Caribbean, hanging out on my yacht, and I'd have it all figured out. I do not have it all figured out. I do know that we have some guidelines now, but they're guidelines. And again, I'm going to come back to that. I keep saying I'm going to come back to that. That way you keep listening. So either way, trying to figure out where I'm going with everything. So what was happening is that some percentage of people who have lost somebody, and at any given time, about 60% of people are bereft, are in the active process of grieving. That is a huge amount of people. We have, 330 million people just in the United States. And this is found cross-culturally. This isn't just something found here in the United States. About 10 to 15%. And that depends on the researcher. Some say 7 to 10, some say 10 to 20. I'm going to say 10 to 15 with the understanding that I'm just kind of, break in the middle there. About 10 to 15% of people who are bereaved have what we would call prolonged grief disorder, the way we would define it now. Again, there are some people that say there is no prolonged grief disorder. There's just grief, and sometimes grief gets stuck. Then there are other people that are saying, no, there's prolonged grief disorder for sure, and we're going to go ahead and stick it in the manual that mental health professionals use in order to, quote unquote, diagnose somebody. And then other people get angry at that because now it's like, oh, okay, well, pharmaceutical companies are going to try to medicate this disorder, and you're right about that. In my opinion, I do think that they are going to try to do that. And I'm allowed to say that on my own podcast, but I have to be careful in other places. But I'll have to be careful here. All right. So prolonged grief disorder. So it was confusing because there was, before, earlier in the 2000s, there was a belief that you could not diagnose major depressive disorder if it was within 2 months following the loss of a person. It was called an exclusion criteria. All right, neither here nor there. What they were trying to say is you can't assume somebody is depressed when they're bereft. And apparently you get a 2-month period of time. Problem was, from some researchers, they were saying, wait a minute, you are potentially overlooking people who actually do have major depressive disorder and are grieving. So there's that group of people. There's this other group of people that are saying, no, you don't want to pathologize somebody who's grieving and turn around and say that they've got major depressive disorder. Grief is not a mental health disorder. We are all going to grieve. It is a process that naturally and organically unfolds. That process, again, naturally and organically unfolds in a very painful and difficult way sometimes for about 85 to 90% of people. Okay. What about this other 10 to 15%? When I say people are stuck, and there's been different words for it: complicated grief, traumatic grief, prolonged grief, um, uh, persistent complex bereavement disorder. That was another one that was flying around. Right now, what's out there is prolonged grief disorder. These are individuals who have not had the ability to adapt to a loss. And for a long time there, like I said, it was there a major depressive disorder. You can't diagnose it. Okay, well, we're not going to, diagnose major depressive disorder. Maybe we're overlooking people. What if they're suicidal? Now we've got a big issue. What if we're overlooking that? There's a lot of what ifs, never clear. What is clear, though, is I have worked with people who 30 years after a loss, they are sitting in my office, and you would have thought that the loss happened last week. The intensity was that high. They're not functioning. They're not re-engaging in life. They feel like part of themselves have died, and they have not been able to restructure their identity. They feel like life is meaningless and very unfair, that they're maybe even emotionally numb. So 30 years later, if there's no adaptation to a loss, if we've not been able to make sense of it, if we've not been able to weave it in and then re-engage in in the goals that we have in our lives, and if we're still avoiding things that are reminding us of that loss, like perhaps the person died and it was at this house over here, well, you could totally avoid going over to that house, or even driving by the house, or even driving by the neighborhood. And here's the other thing. Some of this is understood. If I lose my child, part of me is going to feel like part of me has died. That would be a natural reaction. But that one reaction does not mean somebody has prolonged grief disorder. All right. So now the way that things stand is there's something called the DSM. I mentioned it earlier. The DSM is the Diagnostic and Statistical Manual that is used for mental health professionals to identify and define, and I just mentioned this, identify and define mental health disorders. It's meant there to be a guide. It is not meant to be like, okay, boom, person fits in this category and that's what they have. When you have a clinician who's pretty savvy, they have the ability to look at that and determine whether or not, does that really fit? Okay, yeah, they can fit into all those criteria, but there's all these other circumstances. Or this person was, as they were growing up, was abused throughout their lives. We call that complex PTSD, post-traumatic stress disorder. Complex PTSD. Does that mean, those symptoms that you see, I know I'm getting off subject, but I think it's important to hear. Does that mean that chronic PTSD can't look like another disorder, and then that person gets misdiagnosed, and now we're over here giving medications for something that they don't even have? Can that happen? Absolutely. Does it happen? Yep, sure does. So having somebody with enough experience with grief and trauma can, definitely help make sure that we're on the right path and we're working towards treating the right thing. So I think we need to be clear about how we're looking at what prolonged grief disorder is now. And the way that we have it now is that they're saying it has to be, and when I say they, it's like this group of people who were on this committee when they were putting together the new DSM, which just came out in March of 2022. If they have their timeline of 1 year. So the loss had to have been at least 1 year. For children and adolescents, it's 6 months. How did they come up with the year time frame? That's a great question. If you go into the literature, you can see people are all arguing with each other. And you'll see that they're saying, well, we don't want to pathologize people who are still really active in their grieving process throughout that year. But other researchers are saying, but wait a minute, hold on a second. I can see that through 6-7 months, if that person, there's no movement at all, the prediction, there's a likelihood that at 12 months, they're not going to get any better. So we've got two sides of the coin, and they're arguing with each other, and they're always going to continue to argue with one another. As a thanatologist, as a grief specialist, if I have somebody come into my room and they have lost a very good friend, that's one thing. If they've lost their child or their spouse, am I going to say, oh, 12 months, you should be really on your feet now? No, I'm not. I've seen people who have lost children and lost spouses, and it's taken years to get to a place. But I'm looking for things. I'm looking for shifting. Are you re-engaging in your life? So they say 12 months, 6 months for kids and adolescents. Now, one of the two have to be present. This like intense yearning and longing. It's almost like this massive separation anxiety that doesn't seem to ever reduce. No matter what you do, it's just this intense yearning and longing. Or you're really preoccupied with the person, the lost person, or of the circumstances of the death. So one or two of those has to be present. And then, just like every other mental health disorder, there's a whole bunch of different criteria. And you have a list of 8 criteria, and you have to meet at least 3 of these. And they have to occur daily, and they have to occur to a significant degree. So examples of this, I've mentioned to you: marked disability of the death, the emotional numbness, feeling like part of yourself has died. You might have feeling that life is meaningless, feeling like this intense rumination, thinking about it over and over and over and over again, reintegrating into your life, like engaging in new activities and new relationships, new life goals, being able to engage in a life that exists without that person. Now, this, just so you know, prolonged grief disorder has to be due to the death of a person. In another podcast, I talked about non-death related losses. Nope, doesn't apply. This only applies to the death of a person, which is another area of contention for a group, for a whole big group of thanatologists and researchers in this field. So there's some argument about that. The fact that it's even in the DSM, that's been like a huge win for thanatologists. Before this version of the DSM, there was something called persistent complex bereavement disorder, and that was placed in the part of the DSM that you couldn't diagnose it. It was there for future research. All right, fine. We did a lot of future research. We finally got it into the DSM. In my personal opinion, and let me just point this out, an avoidance of the reminders. I talked about that. That's huge because if I'm working with you as a clinician, one of the things that I'm going to talk about is how do we reduce the amount of avoidance that you engage in. That's actually part of a treatment for somebody who is dealing with marked disbelief about the death and so forth. Now, this disorder, there can't be another disorder that better explains this disorder. But what's really important to understand is that this has significantly different criteria that is separate from any other disorder. And I'm not just talking about like the symptoms that you see. I'm talking about like physiologically. People with prolonged grief disorder, their heart rates are lower. That there's issues with being able to, like there's cognitive processing, thinking processes that are different. Being able to solve problems is challenging. That rumination, and what I mean by rumination is like going over it and over it and over it again, that actually keeps that loss in like your working memory. Your working memory is like if I said, okay, I want you to remember this phone number. And if you're like me, you'll remember 3 numbers and then you'll have to tell me what the number is again. I'll get to 5. Eventually I'll get to 7. And, calling the pizza place is already too late. But it goes around and around in your working memory. You can't stop thinking about it. All right. Because of that, it doesn't eventually get into your long-term memory. Because when you think about something over and over and over again, you're not allowing your brain to release the attachment to what you're thinking about enough to engage in the rest of your life so it becomes part of your autobiographical memory. It never integrates. So instead of it going from like this acute grieving process that often had that intense sorrow, the intense pain, the intense, like physical symptoms, these interpersonal difficulties you might have after a loss, the spiritual difficulties you might be having, the cognitive and psychological difficulty. There's so many different types of symptoms of grief. That'll be another podcast. I'll come back to that. So you go from that, which is normal when you have a loss. And over time, as you're adapting to the loss, you're processing the loss, you're healing from it, it eventually comes what we call integrated grief. Now, look, some people call it resolved grief. I don't think grief gets resolved. I just think that's crap. You will carry loss with you for the rest of your life. There is like resolution to me sounds like there's going to be some kind of closure per se, where you're leaving something behind. Hopefully you find closure, and that's a different concept, but I don't mean the kind of closure where it's resolved, oh, I'm good with that, off I go. There are going to be some losses where you're like, now I've come to terms with it, I'm good. But there are going to be other losses where you're going to continue to carry that loss with you. And again, in this case of the prolonged grief disorder, we're talking about the death of a person. So I just want to let you know, I'm aware there are other losses that you can carry for the rest of your life, but right now I'm talking about death. So carrying this loss with you in a way that does not allow you to redefine your life goals, where you have these kind of bittersweet memories. And what I mean by that is like, okay, I'll give you an example. And I like to use my loss of my brother as an example because it's the loss that impacted me the most. It's the one that got me here in front of you. So again, I grew up pretty poor, but stockings were a big deal for Christmas. I mean, my mom would wrap, a candy bar. Anything she could wrap, she would put in here, right? So these were a big deal for us. So be going through I'm 14 years old, my brother's 10, and I'm going through the stocking, and at the bottom of my stocking is like a bunch of chalk. I'm like, what? Who put chalk in the bottom of my stocking? And like, proud as can be, like a damn peacock, he's like, I did. And I'm like, why would you put chalk in the bottom of where's the box? And he had a perfect answer. He goes, made it look like there was more. And you know what? Sure as shit, he's right. It looked like the whole, but now all of my stocking was ruined, and that's okay. But yeah, he thought about getting me chalk. Now, I'm not sure what a 14-year-old's going to do with chalk, kind of outside of the hopscotch range, age range. But he got me chalk. Now, interesting enough, he died on Christmas Day in 1999, and this is a Christmas memory. But that's a bittersweet memory. As I'm sharing that with you, like my heart's getting real big, and I'm remembering his face, and I'm remembering how I felt, and I am feeling the love in that moment. We had a difficult relationship. He had bipolar disorder and ADHD, and it was very, very challenging to live with him at times. But this is one of those memories that was just so sweet, but it's bitter because he's not with me anymore. And I carry that with me. And I'm okay with carrying that with me. And I got a whole bunch of other stories that I would be able to share with you that are bittersweet memories. So carrying those bittersweet memories with me. Being able to maintain a continued bond, which is also going to be another podcast topic. Being able to maintain a continued bond with him. Like, how am I carrying with me? He's not right here in front of my face. I'm not talking to him every day. But I don't need to relinquish my attachment to him. Now, back in the day, like 1900s, when Freud was around, he would talk about kind of got to let that person go in order to be able to move on in your life. And research shows that that's not true. Again, and I know I bring up culture a lot, but I think it's important because I don't want to make assumptions. There are certain cultures in which a continued bond with somebody is completely inappropriate. And I'll say that again. You'll hear me say that over and over again, because I do not want a listener or a viewer to hear this and go, what's wrong with me because my family says no continued bonds. That is fine. If that's your cultural background and your belief system, nothing wrong with that. But research does show that when culturally appropriate, having a continued bond actually allows somebody to integrate that loss into the narrative better. And then also being able to accept the reality of the loss. What? Accept the reality. like it's okay. No, that's not what I'm talking about. Accepting the reality that it has happened. So you will hear people say, I still cannot believe he's gone, or I refuse to believe that he is gone. You're not quite integrated yet then. All right, keep working towards that. Allow that process to happen naturally. I can't believe he's gone. I've worked with people who literally years and years later will pretend they're living in another state because they cannot accept the reality of loss. It's too disorganizing. It's too painful. So accepting the reality of the loss, not avoiding reminders of that person, being able to tolerate. We have something that's called the window of tolerance. I don't want to get too off subject here, but I think it's important because we're talking about navigating emotions for all this. So, for those of you who are just listening and not watching this, I want you to imagine a box. And in that box are these emotions that you're able to tolerate in a calm way. That doesn't mean your emotions have to be calm, but you're able to sit with those emotions without feeling completely overwhelmed. What happens for some people is that we go outside of our area of emotional tolerance, our window of tolerance, and you become really, really what we would call hyper aroused. Now, hyper aroused, okay, what the hell does that mean? That means like fight or flight. How do I get out of how I'm feeling? So you're ruminating and you're wanting to get away from however you're feeling, and your heart is racing and your hands are sweating, and maybe you're having panic attacks and your anxiety is through the roof because navigating those emotions is too overwhelming. So you feel completely overwhelmed. So you become hyper aroused. And what we try to do is teach people how to come out of being hyper aroused and getting back into that window of tolerance. And that can be really hard when you are when you are grieving. You're traumatized. Some people live in hyper arousal when they're dealing with trauma. Another thing we work towards is trying to cool that body down when you're in a hypervigilant state, when you're traumatized, because you don't think straight. When you are hyper aroused, the frontal part of your brain, the one that helps make decisions and keep you from doing things and process what's going on, shuts off, lights out. That part of your brain is not functioning during those times. So we're trying to get that back online. Some other people drop down into what we call hypoarousal. And that's more of that depression, freezing up, just no energy, no ability to engage in life, doesn't have that energy to restructure and re-engage into meaningful activities. So as you can see, this up and down. You can go hyperarousal, then drop down to hypoarousal, and then get back into the window of tolerance and up and down. It's an exhausting process. So learning how to cope with emotions effectively with good coping skills becomes an important part of treating complicated grief, also known as prolonged grief disorder. So you have to have somebody who is savvy and educated enough to be able to say, yeah, you might meet all this criteria and all, but there's all these other extenuating circumstances. Or, yeah, that might be here, but this other thing over here, like this anxiety over here, we have to treat that anxiety first before I can start getting into helping that person's prolonged grief disorder get onto an uncomplicated grief trajectory, getting you back on track so you can metabolize that grief and you can integrate that grief into the narrative of your life. So that's what prolonged grief disorder is. If you do need help with that, please reach out to somebody who is trained in prolonged grief disorder therapy. I know there's not a whole lot of people out there, but you can read up on it. You can reach out for support. There is the prolonged grief disorder clinic at Columbia University. Sometimes they have a list of people who are trained in prolonged grief disorder. There are other types of interventions, but don't stop. Keep looking. If you think that this applies to you or for somebody else, I hope that this podcast brings you some awareness to try to get you back on track to heal. Have a good one. Thank you for listening to Phoenix Rising with Dr. Z. If you found this podcast helpful, please share it, subscribe, and leave a rating or review wherever you get your podcasts. We want to be a resource for anyone who's experiencing loss, and this is a simple way you can help us spread the word. Check out our show description. There you'll find a link to connect with me on social media, as well as helpful articles and resources.